Good morning, everybody. Dr. Gabriele Jasper MD, interventional pain doc with Jeremy.
Yeah,
On Painless with Dr. Gabe Jasper.
that's right.
Yeah, we're going to talk about a few topics today, try to change it up a little bit. But in the beginning, I like to always talk about what I do. I do interventional pain, and interventional pain is where we find the pain generator, and we use some type of intervention, and 99% of the time, probably 100% of the time, it's minimally invasive.
Yeah.
We do no invasive procedures. We do short procedures, sweet, precise, under strict guidance, X-ray, ultrasound guidance, or actually open procedures to get rid of pain, especially the common types of pain, sciatica pain, the spinal stenosis, arthritis of the spine, reflex sympathetic dystrophy, and we've been dabbling a little bit in post-traumatic stress disease, where disorders, where there's procedures that actually help that.
Really?
Yeah. But yeah, I mean, today, and we're also going to talk a little bit about the Medicare, I call it disadvantaged programs versus the traditional Medicare.
Yeah.
Because that's a big topic today. In fact, I usually before the show I go on YouTube videos, and I see and I go over and see what's the latest on Medicare Advantage and the pros and the cons. And today I actually looked up class action Medicare Advantage, and there's multiple class actions out there. So it's also going up to the Senate. They're talking about it in the Senate. McConnell, all these guys are talking about this Medicare Advantage and how people are actually getting so screwed over that it's ridiculous. There's some I wrote down at home a few things that I wanted to mention. For example, you do not have any say, your doctor has no say in what your treatment plan is and what treatment you can have, right? When you have Medicare Advantage, disadvantage. Whereas Medicare will pay. Medicare Advantage will pay what they want to pay, even though they promise you that they will pay for anything Medicare will pay for. But at the end of the day, they don't do it, and nobody does much about it, because most of these people that I hear are with this class action are people who need more than 100 days in a facility for, let's say, at the end of your life or something, hospice and things like that, where, this is where Medicare comes in strong, where they take care of you over 100 days. Some of these Medicare Advantage plans, I heard on this class action, there was one lady that after 70 days, they cut her off. And the family was responsible for $160,000, and the patient eventually died. But can you imagine having Medicare that will take care of that, and they talk you into going into Medicare Advantage, and at the end of the day, you owe $160,000 a family?
That's messed up.
Somebody's inevitably going to die.
Yeah.
What do? It's illegal for euthanasia. We won't even talk about that.
Yeah.
But and another same incident, $70,000 they had to take out of pocket, and they're all fighting it. You got some big time lawyers. In fact, I have a patient that I want to talk about. I do a procedure where it is, for spinal stenosis. I put these spacers in. Excuse me, my nose is running. But I put these spacers in, and the spacers have been a game changer for many, many years.
Yeah, they have.
And Medicare pays for it without a blink of an eye.
You've been saying that the first time you discovered it,
Yeah. Why do they pay for it? Because Medicare pays for it because you deserve to have things paid for when you decide, your doctor decides to treat you. Number one. Number two, it works. And we've proven that it works. I had a patient that was denied 4 or 5 times from Aetna Medicare, saying that it's experimental and we don't have enough studies on it. And then when you go review the studies that they send you, guess when they were done?
When?
2002.
Jeez.
That's 22 years ago. They're basing their decision on whether you can have the procedure or not.
Yeah.
Oh, you think there's no studies that have been out? That's when it first started. Of course, they didn't have any studies.
So they're not exactly looking out for you.
No,
Yeah.
no.
Yeah.
They pay these CEOs, the people that pay. They have a Medicare has a goal. You need something, they pay for it. And I say it again. Medicare Advantage, you need something, they decide whether they want to pay for it or not.
Yeah. Or whether you really need it, you
No,
know?
it's not even because if they really need it, you really need it.
Yeah. 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 Yeah.
They just pay
No,
for
you're
whatever
right.
they make up stories.
You're right. Yeah.
You know, I mean, I had a bunch of stuff written down that how you got to avoid these Medicare Advantage, and now it's going to be difficult for anybody to go back into it. Medicare, they don't tell you that that once you get into Medicare, and what they tell you is they make it look like this is just part of Medicare. You know, it's like Part D of Medicare. It's not Part D of Medicare. It has nothing to do with Medicare. It's completely different. It's run by these big insurance companies, Aetna, United Healthcare, Braven, which is, I think, Blue Cross Blue Shield. These are the people that run your healthcare.
Yeah.
And their goal is to pay less. You know, their philosophies, we need to pay less for procedures and make more profit.
Yeah.
It's a guarantee. That's what they say. Actually say this. And be wary of the salespeople who sell you these things because they make a lot more money selling you Medicare Advantage than they do selling you a secondary for Medicare.
Yeah.
And I mean, I could go on all day and I get upset about this, you know.
And Medicare is the word Medicare is not copywritten, so anybody can use it. So you got to really be careful.
The fact that they put in there Medicare Advantage, that right there is deceiving.
Right.
Medicare Advantage, it's not Medicare Advantage. It's not Medicare Advantage. It's Medicare Disadvantage. You know, but well, maybe we'll touch back on that a little bit later. But you know, let's talk about some of the things. You know, it's a new year.
Yeah,
this is our first show of the
Happy
New
New Year, Doc.
Happy New Year, everybody. 2024.
Yeah.
We made it. That means I'm in my 28th year of practicing pain.
Wow.
Anesthesia, pain, surgery in my life. You know, we're pushing 30 years now.
So you're the master of pain. Let's just say that.
You know, I was referred a patient by a well-known doctor, Ken Candido, who is a world-renowned professor at the university in Chicago. And believe it or not, he was one of my mentors when I started.
Huh.
When all this the evolution of interventional pain, when we went from doing blind epidurals to actually treating patients more accurately under ultrasound, or actually in those days it was just X-ray, which was a breakthrough on the accuracy of how you treat patients.
Yeah.
You know, but lower that down a little bit, get a little bit, my hands involved there.
Sure.
Yeah. Anyway, so he was my mentor. In fact, you know, I was working at community medical center doing pain, and we were just doing epidurals, people leaning over and popping it in.
Uh-huh.
And the surgeons used to send us to patients, and then they'd fail a series of 3 epidurals and go back to the surgeon they operate on. It's a major influx of patients once a day, all day long. You know, I only did 1 day of pain, and then I decided to leave. I didn't have time or the money to go learn how to do the advancing stuff started coming out. And this is around 2000, 2001, 2002.
Right.
And this, and Dr. Ken Candida, he was, you know, the professor. And I found out about him, and he was giving courses down in Florida, all over the United States. And I went, among other courses I took.
Sure.
I did as many courses they had out there, and I started to become the leading guys, one of the leading guys in the world with the interventional pain. But I started with him, and he came up. He's got a summer house over here.
Does he? Yeah.
So he comes up once in a while down here in New Jersey, to Jersey Shore from Chicago, because I think he's originally from here.
Yeah.
And he sends me he sends me a video of a friend of his who he sent to me originally. And I saw him. He didn't have an MRI. I sent him for an MRI, and he's right on the video. He's telling his friend and myself that I'm the best in the world of doing what I do. And that's a major compliment.
That's a hell of a compliment, man.
From one of the main Mozanes.
Yeah.
You know, he's probably around my age too, maybe a little older. But anyway, he's going to need that procedure. But going back to the other guy, this other guy, he was denied 3 or 4 times. This guy I noticed him. I didn't really notice how bad he was initially because I would come into the room. We do a physical examination on him and everything. And when he stood up, he seemed to stand up pretty straight with a lot of grimacing. But then I caught him leaving, and he walked out completely bent in a 90-degree, bent 90 degrees. I walked up there and said, "Is that how you walk?" He goes, "Yeah, doc." He goes, "I can't walk more than 10 feet, and I automatically go down like that's the only way I could walk." You know, I recommended getting a walker or something because that can't be healthy or stable. You fall over. And he ended up getting it. Meantime, we gave him some epidurals. He felt better, but not lasting. He needed the spacer, the one that opens up the spine, as we always talk about. How you know, when you sit down, you feel better because this part opens up. You stand up, it collapses, and somebody's playing with my models here. And so when you sit down, this opens up. You stand up, it collapses. So he had to lean almost 90 degrees, 90 degrees, not almost, to get this opened up so that ligament didn't touch his nerves. He had two levels that were bad. Finally, and believe it or not, well, most people believe it, but the instrumentation that you use to put in there is made out of titanium. Stupid expensive. Probably way more expensive than it actually costs them to build, to make in a machine shop or wherever they make it. And what you're paying for is the fact that it probably took them years and years with millions and millions of dollars to get it FDA approved.
Right.
So now they're making up for that. But so it costs a lot of money for these spacers. And he said to me, after having no life for months and months and months, pushing a year, he said to me, "Doc," he says, "can I pay for this out of my own pocket?" And I was like, "Sure, you could pay for it in your own pocket, but it's ridiculous money, thousands and thousands of dollars to do this." He goes, "At this point, I don't care. You know, I'll get the money up. How much would it cost?"
That's desperation.
Oh, yeah.
Yeah.
I wish I could show the video of this guy before and after.
Right.
I don't know if you could do it on this thing, but you could always try.
I could figure it out. Yeah.
But anyway, he ended up paying, but what I ended up making on it, not when I say I don't make that much money. It all goes to the instrumentation. It goes to my overhead. It goes to my nurses. It goes to the medication. It goes to the anesthesia. It goes to everything. And the amount of money that was actually brought in was very little. But I felt so bad for him. And I said, "Do it at this amount of money." And he was so happy that, you know, it was still thousands of dollars, you know, but not half as much as it would have been if the insurance company, if it was Medicare.
Yeah.
It was like half of what Medicare would pay. You know, I just felt so bad for the guy. But to resort to that is bad. I mean, this guy, if he had Medicare would pay for it. And this is, and he actually now, he bopped into the office the other day like a normal human being. I see, corner of my eye, I see somebody walking in. I didn't know the guy was over 6 foot. Guy's standing up straight. He's got his belt on because I telling him to keep his belt on for a few weeks. It's been like 2 weeks post-op or 1 week post-op. No, I did it before the holidays. So about 2 weeks post-op. The guy's standing up. He's like, "Doc, I cannot believe I got my life back." He had severe pain down his buttocks into the back of his thighs. Severe.
Yeah.
The more he leaned forward, the better it was, but he still had to even lean forward. He got off that table. I got a video of him getting off the table, standing up straight, thanking everybody to the point where everybody started crying in the recovery room.
Oh, God.
Even his wife said, "I have not seen him like this for months and months and months." He's
God bless him, man. God bless him.
And it's a very simple procedure with a small incision. And I put 2 of them in. So I had to pay for 2 spacers, which is pretty expensive.
Yeah.
But you know what? My reward is watching this guy stand up and walk.
That was an early Christmas present.
I'm just wondering if we get that video up, if we could actually show it, like, you know, you know, like through the
magic of
you know, you know, it'd be a little stupid, but you know, it's you know, showing it through the camera here.
yeah.
But I don't know if we could do
We've
that.
done it before, and it's worked pretty good.
I gotta find it, you know, but it's amazing. You know, I'm gonna try it, and if it works.
Yeah.
Oh shit. You're holding yourself up with your hands.
Yeah, I'm bracing to like the top on my leg.
Can you focus that? No, you can't focus.
Yeah.
And this is him just before the operation.
Yeah. I mean, yeah. Wow.
Yeah, they said it wasn't medically necessary. That's how the guy had to walk around.
Right across here.
His hands
And across here.
balancing on his thighs just to be able to hold his balance.
That's him before the procedure, and here he is right after. I did it again.
Walking this far in my house, I needed a walker. I needed a walker.
Oh, MG. He
He's
is
standing up straight. He's a different man.
upright, man.
He just got off the stretcher.
Pain going across the back of my rear end, and then pain going down the back of my legs and the thighs.
Oh
And it went down to the knee. I don't have that. The only pain I have right now is in the area of the actual surgery, which I expect.
Fantastic. So what do you think? What did you have to say about his stance?
He walked like an old man and shuffled like that. Like he could, and then he would, sometimes he drops.
Not doing that now.
No.
This is the best that I've seen.
This is the best I've been in months. Months.
And he's just going to get better and better now. You know, because now it hurts him, you know.
I can't thank you enough for everything you did.
My pleasure. My pleasure.
I mean, your staff saw me come in here so many times. I getting procedures, and it's all worked.
Oh, God bless him.
Somebody how it works.
It's a little too early to make any irrational commitments. Everybody started to cry at this point
Yeah.
because they knew him.
Did the mild procedure that the insurance company said the only alternative was they were allowing that, and you saw how I left with that.
Yeah.
I was the little old man.
Well, you know what? One of the reasons why you're doing so good now is because you had the mild.
Okay.
So that was an adjunct to this.
Okay.
Hmm.
But I'm not complaining. I'm happy. Right now, I am happy.
He has perfect posture.
Yeah, look at him. He's standing up straight.
Yeah.
There's Jake, but
And look how long he's been standing.
I know.
it's good.
He doesn't even look like he's squirming, you know, like with pain.
Yeah.
He's just standing there.
And then he pops in, what was it, a couple of days ago. And I took another video of him.
Did you?
Hold on. Do I have it here? I mean, here's a picture of him just walking in there, you know?
Oh,
I don't know
yeah.
if I got a video of him. I think I did.
You got to send me all that. I want to put that together into one video.
I thought I took a video.
Tell a story about that.
Yeah, I thought I took a video. I probably had it like this and thinking I took his video. 10 minutes. Typical. But look at how he's standing.
Yeah, yeah. Oh, he looks amazing.
Too bad. Too bad I didn't get that video. But I mean, that's and I'll mention it. That's from it's called The Minuteman by Spinal Simplicity.
Right.
And it's amazing. It's an amazing procedure. And you know, we do the mild procedure with minimally invasive decompression of the spine with these contraptions here that they go in and take some of the ligament out.
We've never really gone into detail about the mild and what that does.
Well, I did it last time, but what
Did you?
it does is it takes out some of the ligament that, like with him, for example, he had a big, gigantic ligament, and you actually go in, and you take some of it out like this under indirect visualization using X-rays, and you snips it out very safely. You don't go through the ligament. It's made so it doesn't go through the other side of the ligament. You're just taking whatever ligament is closer to you. You don't actually take it all out, because if you do take it all out, you have a chance of maybe puncturing the dura or neural structures in the
Right.
spine. So it's designed especially for that, but it's limited. And if a person doesn't have severe spinal stenosis, you can just get away with something like that.
Right.
And it's successful, but the combination of using that with moderate to severe central canal stenosis and using the spacer, the Minuteman by Spinal Simplicity, they do phenomenally well. You know, I learned early on that if you have somebody with moderate to severe spinal stenosis and you just put spacers in, the success rate is not as good,
Right.
unless you do this first. So we got a nice protocol on that right now.
That's great.
You know what we've been getting a lot of lately is our patients with sacroiliac joint. And I wanted to bring in the model, but the sacroiliac joint is where you have the base of the spine, you have the sacrum. For example, here's the vertebral bodies, right? And then at the base of the spine, you have the sacrum, which is connected to your pelvis. So where the pelvis, which the ilium, is connected to the sacrum, it's a joint, and it's a Jagger joint, you know,
Right.
and it's not supposed to move. But you get sacroiliac joint problems, arthritis, and pain, mostly in the women who have had children or have been on birth control that didn't have children, and you know, not old, but up to, it could start when they're 40 years old. It could be caused by a trauma.
Mhm.
But what happens is it becomes that joint is held together like most joints by ligatures, you know, that's a ligaments, ligatures. So it ties it together,
Right.
right? And it not supposed to move. But when a woman becomes pregnant, all of those ligaments become loose. Also the symphysis to let the baby out of the pelvis.
Yeah.
And sometimes it just never goes back the way it's supposed to. And then over the years, it moves and moves and moves. And that's not to say that it doesn't happen in a man, because it does happen in a man, just not as often. And it's for other reasons, for the way they work, the way they walk, genetics. And it can happen in a woman that never had. In fact, I had 2 women this week that have it that never had a baby. One was on birth control, the other one wasn't. But it's not like you're destined to get it if you had a baby or if you're on birth controls. It's just those are the people that fall under the category of a higher incidence of having it,
Right.
or being most likely to get it.
Yeah.
And we do maneuvers. We have certain types of maneuvers in the examining room that we lay them down on the table and we stretch the leg this way, that way, bend them certain ways, and they have to feel like there's maybe five or six maneuvers, and got to be like 2 or 3 of those maneuvers got to be positive. And once you do that, we do what they call as a diagnostic injection, where we put an injection in the SI joint, and we put a little steroid. And just like any joint, like a shoulder joint, knee joint, hip joint that has arthritis at the beginning of arthritis, you drop a little steroid in there, you can go years without any pain. In fact, the majority of the patients I have that have SI joint pain, I do that injection and they don't need anything else. Maybe they come back 6 months, a year, 2 years down the road and get another injection. But the ones that, it's been quite a few lately because I've been concentrating on it, and where they have the SI joint problems, I give them a block with the steroid. They come back 2 weeks, 3 weeks later, and they say, "Doc, I felt great for 3 days, or I felt great for 2 hours," because that's how long the numbing medication works. So I'll do another injection, and if the other injection is the same, where they have a short duration of the symptom-free pain, then that's positive, and then they're ready for the next step, which would be a fusion. They call it fusion. Now, it's not like, you hear fusion, everybody gets nervous. It's not like a fusion of the spine. The incision is like an inch, maybe an inch and a half big, usually about an inch. And it's right now there's tons of, and the reason why it's more popular now is because we're making better ways of diagnosing it, and the treatment for it is better.
Right.
The old days, we used to do major fusions for it. They used to fuse it, pin it straight across. I mean, it was major surgery with major incisions. Today, it's 1 inch incision, and you go in there with maybe 2 screws, 3 screws, and it's all lined up perfectly. And it takes a very short period of time, very minimum trauma, right? And you're done, in a short period of time. And it's the same day surgery. You don't even need general anesthesia. You need sedation, like a colonoscopy type with propofol, maybe a little Versed. But they get out of there. I did a lady about 2-3 months ago, and she was the pain was gone when she left that day, kind of like that guy.
Right.
She had soreness from the procedure, and then she came back a week later with no more pain, 95% pain free. She said
Right.
she felt the incision, and then she came back like 5 months later, still the same. She has other pain, but that SI joint pain, which was gnawing at her for years, gone.
Wow.
You know, so and that's usually how it goes, and you do great, very fast recovery. So that's one thing that we need to. If anybody out there, has had facet joint injections, because most physicians don't have the tools that I have in my tool shed.
Yeah.
And that's another topic that Jeremy wanted me to talk about. And there's so many pain doctors out there that are fantastic pain doctors, but they don't have the tools in their toolbox that I have. They're limited to what they call the bread and butter of pain. The bread and butter of pain is epidural injections treating arthritis, and a couple little things here and there.
Yeah.
Maybe injecting the joints, but half of them don't even inject in the joints, or they don't inject them in the right way with ultrasound or X-ray. But I anytime anything new comes up in the Jasper spine, is to whoever's working with me, we know the new stuff.
Yeah.
And the new stuff that's not good, we don't do.
Right.
There's always that stuff coming out, and you got to be careful if you're getting 5 or 6 sacroiliac joint injections a year. You got to be careful if you're getting 4 or 5 epidural injections a year and they don't work. It's time to move on.
Right.
And I understand the reluctancy of somebody not moving on from their pain doctor, because a lot of time the alternative is go to get big major spine surgery. And be leery of the doctors who actually work with big spine surgeries. Not all the time. I work with big spine surgeries, surgeons, but we don't work. They have their practice and I have my practice. If they need me, they use me. If I need them, I use them. It's not like we feed each other based on the lack of experience that I have in treating people with minimally invasive surgery. And the ones I work with, like Dr. Radcliffe,
Right.
he is way ahead of his time when it comes to minimally invasive spine surgery and treating patients conservatively with spine surgery. And that's what I like about him.
Yeah.
He's an honest guy, and he's great hands, great surgeon. So we work very well together. And there's other. He's not the only surgeon that I work with. Quite a few others that send me patients because they don't do that particular procedure, like kyphoplasty. Kyphoplasty. Some surgeons don't do it; they don't want to do it. I've been doing kyphoplasty for compression fractures when you break your back for more than 20 years. So it's like second nature for me to do it. Very careful. You got to know what not to look for and how to keep the patient safe.
Yeah,
that's very important. But yeah, be careful. If you're out there and you're just not getting anywhere with your doctor, and some of them will admit the fact that this is the most I can do. This is all I can do for you, and then you can come to see us, and we could do a lot more.
right.
Especially if you have spinal stenosis, especially if you have sacroiliac joint, and like I said, this PTSD. It's not a big procedure, but we have. Give you a little background of PTSD. It's post-traumatic stress disorder where people, for their own reasons, or not their reasons, but for different experiences that they had in life, caused this problem.
I'll say right now, I was diagnosed with it. I have it. Yeah.
Well, a lot of people it's originally from wars.
Yeah.
They used to call in World War II, I think, shell shock.
Shell shock
Syndrome or something. But now they have it. And I had a guy come to my office. He's like 22 years old, around 22 years old, that has it. I didn't feel comfortable asking him why he has it. Because the guy was embarrassed as it was, but he came seeking the treatment, which is a smart kid, knows the treatment for it. They give you all kinds of medication, but they have this procedure called stellate ganglion block. See, our nervous system is divided into 2 different types. It's the autonomic nervous system, which is divided into sympathetic and parasympathetic. And then you have the voluntary nervous system, which, is involved in movement, mostly movement, thing that you command, right? Motor function. But the sympathetic nervous system is divided into the parasympathetic and the sympathetic, right? And the sympathetic nervous system is made for fight and flight. In other words, if somebody wants to beat you up and you got to fight them, or you got to run, get out of there, like in a war situation or a gang situation, or somebody threatens you, automatically your body kicks into the sympathetic nervous system, and the sympathetic part of the sympathetic nervous system. And what that does is, just for a few examples, all the blood vessels in your intestinal system constrict, because at this point you need to fight or flight or run. So you need, and then all the muscles dilate, the blood vessels in the muscles dilate to give your muscles more oxygen and nutrients in order to be stronger and be able to get the hell out of there or fight. And at the same time, your your pupils dilate to let more light in, and your blood pressure goes up to pump more blood out into the vessels. Your heart rate goes up, and that is what it's supposed to do. It's like a dog. When you see a dog and the hair stands up, that's your sympathetic nervous system. Whereas the parasympathetic nervous system is a system where it's for digestion, relaxation. Most of the blood circulation is now going into your intestinal system. Usually maintains the brain and the heart at an even keel, both ways, sympathetic and parasympathetic. But when you're relaxing after dinner, watching TV, you better hope you don't get into a fight. And that's precisely why when we're kids, they tell us after we eat, you don't go in the water.
Really? That's it?
That's the reason why. It's not 100% myth.
Huh.
It's a little exaggerated. Like in Italy, you go to Italy, the beach is packed until 12 o'clock. And then they all go home to eat, and the beach is totally empty until like 4 p.m. because they're afraid to touch. They will not touch the water.
Right.
That's I'm sure other countries are like that, but that's a little exaggerated.
Yeah.
But the reason why is because if you happen to eat like the kids are eating, and now they jump into the pool and they're swimming around and running around, well, most of the blood now is in their stomach, in their intestinal system. It is not that much blood in your muscles. So what happens? Your muscles starve for oxygen and nutrients, and all of a sudden you get this cramping effect.
Right.
And you become semi-paralyzed.
So people who complain about having nervous stomachs, this is what this is, you think? Or could be?
Well, person. That's another anatomy, physiology.
Yeah.
Where people are nervous people.
Because I have PTSD, and I used to just blame my stomach problems on, I have a nervous stomach or something like that. It was like a blanket thing to say, but when you don't know what else to call
Well,
it.
people under stress.
Yeah.
For some phenomenal reasons, it's probably some physiologic. But I'm not a gastroenterologist. But what happens is your stomach, especially on an empty stomach, nervous, you start to secrete more acid in the stomach, and it's empty. So you have an empty stomach with more acid than it's supposed to. It starts to erode the walls of the stomach and give you ulcers.
I gotcha.
So that's basically what a nervous stomach is.
Okay.
The more nervous, the more anxiety that you have, more negative affect, the more it stimulates these acid in the stomach.
Right.
Some people are just naturally born without enough cells in there to protect it. So that's a whole nother pathology.
Yeah.
But what we do is to treat this, we talked about reflex sympathetic dystrophy. And we talked about sympathetic mediated pain, which is the same thing with two different names. Sympathetic mediated pain. The sympathetic nervous system is not supposed to be connected to the nervous system where you perceive pain. But with sympathetic mediated pain, they think it's a short circuit in those two nervous systems, which is not supposed to be there. And like PTSD, the treatment's the same. But and they feel that the post-traumatic distress syndrome is caused a lot by this overriding this sympathetic stimulation of the nervous system. That's part of the theory behind it. Now, and the theory behind treating them with a sympathetic stellate ganglion block, which the stellate ganglion is around C6, transverse process of the cervical spine, near where the cricoid is to the side. That's where you find the stellate ganglion, and it's a big ganglion, like the heart of the nerves for the sympathetic nervous system. I mean, that's one of the main, I don't know, you could call it all the nuclei, all the nerve endings start to like the brain of the sympathetic nervous system. You also have the sympathetic chain, which is in the lumbar area. But if you turn that off for some reason, it's like rebooting a computer. The same with RSD. You got severe pain, burning sensation, allodynia, hyperalgia. Nobody could touch your hand, touch your foot. And what happens is you turn off the nervous system, the sympathetic nervous system. When it reboots itself, you feel better. The same with post-traumatic stress disorder. You turn off that sympathetic nervous system by doing an injection in the neck on the stellate ganglion block, which is a very short, simple, safe procedure when done right. You could do it either under ultrasound or you could do it under fluoroscopic guidance. I recommend fluoroscopic guidance because you make sure it's not in a blood vessel, and you can't be 100% sure with using ultrasound. Mm-hmm. And you need probably not a series of them. You do one, whether it be sympathetic mediated pain, RSD, or post-traumatic stress disorder. You do one and you see how the patient does. The patient will have a relief of symptoms for a certain amount of time. And then every time you do, and when it comes back, you do it again. Hopefully the length of time that it goes away is longer. And when it does come back, it's less severe. And that's the theory behind how you treat it.
Right.
You know, with reflex sympathetic dystrophy or sympathetic mediated pain, they got good medications that they use as an adjunct to the sympathetic blocks, like gabapentin, Lyrica. They're membrane stabilizers for nerves, and they fire less and they feel better.
Well, I'm behind on all of our chats here, so I just want to read them out to you so far. The beautiful Gabriella says, "Nice shirt, Dr. J."
This is my present today. Today for everybody. I don't know if you can see that.
What part of "Don't You Understand"? I can't see the bottom. Here he goes. He's modeling now. Oh yeah. What
it is,
part don't you understand?
It's the old time instruments. It's the old time instruments you see on an airplane. Which, you know, believe it or not, today they have sophisticated avionics on an airplane, right, computerized. But you'll never catch me on an airplane that just has that, because if all your electrical system goes out, you're up Schitt's Creek without a paddle, unless you have these.
Yeah,
these very rarely fail. Huh. We usually have redundant. You got to have a lot of redundancy in an airplane.
And we got Maria Agathanagelu.
You don't speak Greek too good.
I don't. I'm sorry.
Maria, how you doing?
She says, "Best doctor, always helped my mom."
Well, thank you very much. You probably need that spacer. You wanted to walk right? Bring her in.
And we got Gina Greco. Is that Paul's Gina? Or is that a different Gina? Gina Greco. She says amazing. I can't see her picture. Then we got
Joe Nazo.
He says, "Gabe, you performed the same procedure on my mom." And this is when we were talking about milds and spacers.
Yeah.
It was amazing results. You know, you gave her a good quality of life.
Yeah, I love this mom. Great lady, great cook, wonderful person. And she had spinal stenosis, but this is a long time ago. This is a long time ago, and that just proves how long I've been doing these procedures and helping people with it. And believe it or not, from when I did Joe's mother, there's even better procedures out there today.
Yeah,
you know, it's the evolution,
changing lives, Doc.
Yeah.
And then we got Gabriella again. She says, "You perform miracles."
Well, thank you very much. Gabriella brought over little Gabrielito, GJ. Gabriel Hill group.
Yeah, yeah.
Yeah, he's
The little guy that made you a no-no.
yeah.
Yeah.
He wanted to go to Nono's house. I was babysitting for him last night.
Hmm.
He broke a few things, and it took me about an hour and a half to get my TV to work again. He happened to find I got some old he touches everything. He brings it to you.
Yeah,
You know,
yeah.
he's not even 2 years old yet, but but on my where my TV stuff is, like the box and everything, and the CD, DVD, and the stuff over there. On a little, he grabbed a few of the non-working. I hoard everything. You never know when you need a remote
Oh, yeah,
control.
yeah, totally. Yeah.
But he happened to find one. He pressed it, and the whole TV went out. Now there's like 5 of them, and I don't know which one he pressed. So I unplugged it. I rebooted it,
Right.
like giving him a sympathetic chain block. I had to reboot it, and then finally I figured it out. I found out which one he actually used. But we had a lot of fun running around the house playing the ball.
Oh,
And
that's
he could
great.
eat. He had 2 plates of pasta
Oh, he's a Jasper.
with a lot of cheese.
Yeah.
He wants cheese, and also he had a banana for dessert and 2 tangerines. Yeah, oranges. Those oranges,
wow.
tangerines. But he's a good eater. He's solid. A lot of fun.
So-
And Gabriella and Tyler are moving into their new house today down the Forked River.
Yeah.
Congratulations on that.
Congratulations, man. That was
Independent and on their way.
God bless both of them.
Yeah. And believe it or not, Tyler is one of the reps that bring me and help us with the Spinal Simplicity Minuteman, also the kyphoplasty stuff. So he's learning all that stuff, and he's helping Ryan Clark, who's one of the best reps that we've ever had. He's very smart.
Yeah, he's a good guy.
Very smart and entrepreneurial.
Mm-hmm.
If that's a word.
Yeah, that's the word.
And he helps us get some patients in and stuff like that.
Yeah. So then we got a Michael Kachmar.
I heard about him. Did he get his operation?
He had one. I know he had one on his shoulder. He is either he's waiting for the next one or he had it, and he's down for a little bit. But me and Dr. Kachmar are going to be starting up our radio shows again. That's Scrubbing Up with Dr. Michael Kachmar. That'll be coming soon in the next few weeks. I think he's going on a cruise though. So.
Yeah.
But he says you just want to let everyone know Dr. Jasper is the best interventional anesthesiologist.
Well, thank you very much.
Yeah.
Thanks. And he's the best podiatrist I ever met.
Yeah. And then we got Carol Vanderlinde.
Yeah, my parents were best friends.
She
Bob
says,
and Carol Vanderlinde.
she says, great to see you, Gabe. Hugs.
Yeah, I'm gonna have to get out there in Las Vegas to see you again.
Oh, is that where they live? Yeah.
They're originally from Passaic Clifton area.
Hmm.
She was a fantastic nurse. She first assisted in a surgery. I had a what do you call it? The stone in my salivary duct, submandibular salivary duct, where it was stuck in the tube that comes out when you salivate.
Yeah.
It was stuck in the tube, that the duct that gives you saliva, and I don't know how that happened.
Right.
I think years ago I fell off my father's sailboat when it was in a driveway, and I bit my tongue almost off. My grandfather and his friends sewed it back on.
Oh.
And because of that, the trauma of that probably distorted the tube a little bit, and it accumulated calcium and formed a stone. And they had to go in there with Carol Vanderlinde was the first assist in it, and they took that stone out. But the symptoms were ridiculous. I mean, I was young. I was probably maybe 25 years old, maybe 25 years old, and the symptoms were when you're getting ready to eat.
Yeah.
Right. What happens? You automatically salivate, but you don't realize that because nothing's wrong with you. Your mouth gets watery.
It's second nature. It doesn't
Yeah,
even occur to you.
second nature.
Yeah.
But if it's obstructed, it fills up back pressure and won't come out. And I was able to push my tongue a certain way to the side, which maybe stretched that tube, and it would shoot across
out.
the room.
Holy
Shoot across the room.
cow.
But it got to the point where it didn't even want to do that. I couldn't relieve the pressure, especially if like somebody had lemon or something, or even talked about lemon. or you bit into a lemon, forget it. It was like torture. And thank God that was like 100 years ago, and it's still doing good. Yeah, you would think that something else would happen, but I think that the doctor did a great job. I forget his name. Carol, if you remember his name, I wonder how he's doing. What he's up to? He was a good guy. I always liked him, but the name just slips my mind.
I never heard that
Print
story.
Print his name out. Yeah, that was good. Carol was a great nurse, and her husband, great guy, still are, and they were one of my parents' best friends. But anyway, so what else are we going to talk about? We talked about SI joint. You know, when I had that salivary duct operation, I was in medical school in Italy.
Oh,
And when I was in medical school in Italy, I suffered for quite a few months and couldn't wait to get back. It was to the point where I had to have that operation. It was a simple. We did it in same day surgery. But yeah, I was in medical school in Bologna, Italy. And for the people out there that doesn't know much about if you look me up, you could see, you know, where my background is.
yeah,
You know?
yeah.
I was born in Rome when my father was in medical school. He married my mother, and they moved out to Italy. And my sister Carmel was born. I was born. Josie was born. And then by the time he graduated, my mother was pregnant with my brother Ted. And then a few years back, maybe 5 or 6 years later, they had Maria and Vincenza. So it was 6 of us. But those are some of the best years of my life in Italy.
Yeah.
You know, one of the reasons why I went to Italy, number one, my father used to talk about how the country was so beautiful and how we have relatives there. His father was born there. His mother was born there. And the stories about how they met. And I never spoke Italian. I always wanted to learn Italian. And the main thing was that he insisted that the best medical schools in the world were in Italy, you know, not just Italy, but in Europe.
Right.
And the reason why, he said, was because in this country at that point, because of the wars, they kind of shortened the amount of time you need to study certain things. For example, anatomy in this country, they study it for 3 months. In Europe, they study it for, well, at the time, I don't know how it is now,
Yeah.
but in Europe, they study for 2 years anatomy. Physiology, 2 years. Pathophysiology, 2 years. You know, most of the programs that you learn, it's 2 years, where you go to school, you study at home, and you also have oral exams. When people take written exams, the ABC, true and false kind of stuff, there's a technique to take those exams. There's a technique where you can get a good grade with minimum knowledge. Because, you know, statistically, which one you pick, which one you don't, when you guess, maybe it's 50% correct. You know, I don't know how to. I was never good at those. But in Italy, it's all oral exams. You walk into the examining room, and not only oral, the public. So at any given time, you got anywhere from 50 to 150 students listening to you give
Oh,
an
I
exam.
didn't know that.
And they got a table like this where they have the professor in front, and then they got the residents and the fellows next to them. Doctors, all doctors that will ask you questions.
That's a little pressure there now with
Pressure.
with an audience.
Pressure. You know, I remember when I used to go watch some of these exams,
Mhm.
and there's always that little rumble in the background, you know, that the decibels of noise that you hear in the room,
Right.
people talking and whispering. Sometimes you couldn't even hear what they were saying.
That ambient noise.
Yeah,
Yeah,
the ambient noise. But when they would say, Gabriele Jasper, come up to take your exam, you could hear a pin drop. Because now you got the American going up there
Oh, yeah.
and see what the hell he can say. If he could speak English or speak Italian, if he knows how to speak Italian. So that would be even more pressure.
Right.
I mean, I swear to God, every time I took an exam, they have a cafe bar on every corner.
Yeah.
Sometimes 3 in one street. And I'd walk in there and I'd have my espresso. But about a half hour before my exam, I'd take a shot of whiskey just to calm my nerves.
Calm your nerves. Yeah.
Every time I got up, we had 30 exams like that. Every time I got up, it was like I put my clothes out like I was going to the guillotine.
Oh my
Or
god.
the electric chair or something.
Yeah.
But yeah, I tell you what, when you're sitting there and they're in front of you and they say, talk to me about this, they look at you in the eye and they know if you're bullshit.
Yeah.
You know, well, you know, you can get pretty good at talking. And they say when they ask you a question, you don't stop talking, just keep talking. Eventually, you give them the answer if you
Right.
don't know the answer 100%. But they get you, and some of them are good. You know, you get so nervous, they'll walk you through it a little bit, but they know if you know it or not.
Yeah.
If you don't know it, they throw you out. You don't know enough, they throw you out, and you come back and do it again.
Yeah.
And that was very rare that ever happened to me.
So when you're up there and you know, you got all that pressure and you got a giant like audience, what happens? The audience just disappears and it becomes just you and the panel. Is that, you know? Or,
Well, yeah, until I say something, then maybe they all laugh.
okay.
Then
all
they
right.
show up again.
Yeah. Yeah.
No, it's stressful throughout the whole thing.
Yeah.
You know, but you know, luckily I'm the type of guy that I like to talk.
Yeah.
And I would rather do oral exams than I would written exams.
Oh yeah.
You know, but and then, you know, as far as medical school, sometimes I get a patient say, "Doc, how come you went to medical school in Italy? You couldn't get in over here?" That's your typical thing.
That's
And
some
you know what?
ignorant stuff, though, man.
Maybe most doctors that went to medical school in other countries, that was a situation. But I never intended on going. When I decided I was going to become a doctor, one of the reasons why I wanted to become a doctor, because I wanted to do medical school in Italy. Believe it or not, I wanted to
Yeah.
go there. I want to experience my heritage, see the country I was born in. My family's originally from, and guess what? I ended up meeting all the relatives because it wasn't that. You know, I met all my grandfathers, most of my grandmothers and grandfathers' siblings, and you know, most of their sons and daughters are dead now because, you know, they were my father's age.
Yeah. But are you meeting these people for the first time?
Yeah, I was meeting for the first time.
Yeah.
And you meet it for the first time, and half of them look like you, right? And they all treat you like they've known you all your life.
That's
Because most of them
great.
saw me when I was 2.5 years old.
Right.
'Cause that's when I came back when I was 2.5 years old.
That's great.
You know? And I learned the language in an extremely fast time because I guess I have a knack for languages, and it's not hard when you learn it in the country.
Right.
You learn
yeah.
one word, within 10 minutes you heard it 5 times already.
Yeah.
You learn a word here. Like I've been struggling with trying to learn Spanish, but you don't hear it as much
Yeah. You're learning it as it's
because I'm in
spoken.
this country.
Right.
So then I graduated medical school. First I applied there, took the exams and everything, got in there. But you know what I had to do?
What?
I went to make it a little easier. I went to their last year of undergraduate school, called Liceo. And I graduated from there. I had to bring a thesis to graduate, called the maturità, which means the maturity.
Hmm.
And it's somewhere in between. It's probably like graduating here with an associate's degree. Because when you go to medical school or any kind of university, whether it's engineering, law, art, science, medicine, whatever it is, they do a lot of the prerequisites for university that we do in our last maybe year of college. So it's somewhere in between there, and that's what we did. And then I went to medical school, and I took a little extra time to graduate because I just loved the country.
Right.
You know, I used to race motorcycles out there. I used to smuggle gold into the country, you know, the gold chains and everything.
Yeah. Yeah.
And, you know, I got to the point where I was able to support myself. But we had fun. The food was great. The people were great. But the tough thing is, and I think it's even today, anybody go to school abroad, you have to take the exams to come back into this country.
Yeah.
And they were really, really tough. Those exams are really, really tough. But we made it. And it's been, you know, since 1987, I've been here. That's when I graduated, and, you know, doing good.
Yeah.
Went a long way, and I'm not done yet.
Nope.
I don't plan on retiring too soon. It's just too much stuff coming out there. I love treating patients,
Yeah.
and I have like 25 employees that love working for me. At least they make it look like they love working for me.
Oh yeah.
If they don't, I just pay them more money.
Hey, I know I love my job, man. I love coming into work every week.
Thank you very much.
Yeah. Now, in another show, I would really love to hear like more about your time in Italy. You know, maybe the jobs you've had. I know you were like a sous chef for a while, right?
Not in Italy.
Not Italy? No.
No. I was never a sous chef, but when I graduated, I was taking my exam. I had to work,
Hmm.
and I worked in. I was like an executive chef in an Italian restaurant when they used to call them head chefs.
Oh, okay.
We told that story on the air. We talked about
Yeah.
that.
Did you have
I
other
actually
jobs
worked for the
though?
mafia at that time. Yeah. It ended up being the mafia job.
The cousin Astro? Is
His
that it?
name was Vito. Vito. Oh, Vito. Vito. Yeah, he was a guy who just got out of jail and he opened up a restaurant and he was part of the mob and he used to have the mob come over and eat.
Right.
And I used to cook for friends of mine from the gym while I was studying for my exam after I go to the gym. And they knew I was a good chef. And the chef, they would have 40 mobsters come in that night. And the chef got arrested for cocaine the night before. So they came in begging me to cook that night. I never worked as a head chef in a restaurant up
Right.
to that point. But I worked in restaurants when I was younger. Sure enough, I went there and I worked the deal that he couldn't refuse, all cash payment. And I already took my exam. I was just waiting to get the results. And I worked it for about 2 months, 2.5 months, and then packed it. Had like 3. You know, in restaurants you have one serving, and then another group come in, and another three times I would do it.
Right.
But I'll tell that story. There's a lot of funny things.
Yeah, I want to
in that
hear
story.
all about that. But
So probably Barbara Schneider's here, right?
she is. I just heard it downstairs.
Yeah.
So that's Radio Free America with Dr. Barbara Schneider. We talk about patriotism and a whole bunch of stuff, and medicine, of course.
Yeah.
So stay tuned for that, or check it out on Facebook, everywhere.
Thank you, everybody, for listening, and we'll be back soon, maybe next week.
Yeah, definitely. Okay. Take care, everybody.
Bye-bye.
Bye-bye.